last day with Josh on his 6-week rotation here. So he's going to go head back to school. Remember, he's just in his second year of PT school so far. So we're going to do just a quick Q&A, picking his brain with some of the questions that I get from you guys, people on social media, and just his feedback from being here and seeing everything behind the scenes. So coming into the rotation, what did you think of the rotation? Like, you had some preconceived ideas of what it would be like just watching stuff on social media. So what were some things that stood out, like that were different than you thought they were going to be?
Differences in like what you see on Instagram. Obviously, Rhett does stuff different than standard PT. I didn't assume that it would be really one-on-one, which it is. There's no text, which is really cool because you're working with the same patients the entire time, and with the patient the entire time, which is really nice. And then also stuff which we've kind of done videos over of doing like post-op stuff. I wasn't really sure how that was going to work with 180 system. And so it's really been cool to see that precautions are still followed, but like the protocols of you do this by week 6 are not really followed because we still respect tissue healing, but 180 is not of, stretching and doing. There's some passive range of motion, but not passive range of motion like you'd see in a standard physical therapy clinic. So that part's been nice to see at 180.
Okay. And so good example, we just had a post-op reverse total shoulder. Today was her first day out of the sling. So got out of the sling. We didn't follow any protocol with her. She's staying on where my benchmarks are. So today, first day out of the sling, walked in and she was probably like 80 degrees of flexion.
Yeah.
And 80, maybe 70, 75 degrees of abduction. But when we got done, she had 9 degrees of flexion and probably 80 degrees of abduction, which was pretty smooth, and she did well with her home exercise program. So that's the things that I'm looking for patients to hit milestones and be able to do certain things at certain weeks or days post-op versus having them follow a rigid protocol and do certain things and then change certain things. So I let them dictate what we do treatment-wise, as long as they are hitting their milestones, which 99% of the time they're hitting their milestones. So let's talk about your confidence coming into this rotation. So first clinical rotation, what was your confidence level coming in dealing with just patient treatment, patient evaluation coming in versus now?
Yeah, well, to start, it was kind of first time getting hands on patients, getting to ask questions, and like getting in the sense of you're not acting with your classmates anymore, which is really nice, because that's sometimes hard to buy into the acting part. So probably 3 weeks in, I felt a little more comfortable getting hands on, and then now that 6 weeks in, I feel a lot more comfortable at least just talking to patients and feeling less of when I get to a certain point in conversation, brain goes blank. I'm like, oh, what do I do next? I feel less of that and more guided in my thinking of where can we go with this patient and things like that.
So that's going to be interesting to see how much of this you can maintain and do on your other rotations.
Yeah.
So typically, and see if this kind of falls in line with what you've heard and seen from other students that have gone on rotations. Typically, when we get somebody who comes in and they've already done, they've been an aide or a tech at a PT clinic before they got into school, or maybe they've already done a short outpatient rotation and they come in. One of the comments that I get is, well, it's nice when you're not working with a diagnosis because it's easy to change what you're doing as you're going through the treatment. Whereas if you're doing diagnosis-based PT and you're following what you're supposed to do with that diagnosis, you can't really change it after you've stuck yourself in the diagnosis. And then when patients come back, they're not progressing, and it's really hard to figure out how to rewind or change what you're doing because you're already stuck in this pathway that you've had to go through, since that's the diagnosis that you're either told to treat them for by either a referring physician or maybe another PT in the clinic, or that's what you came up with when you went through their evaluation and you went through differential diagnosis and got stuck on a diagnosis.
Yeah, that part's been nice with like non-op patients. I never felt like we were following a diagnosis of a patient in the sense of this is the diagnosis, where can I go next because of that diagnosis. It was more, what is the patient showing on the table? What are they showing in their functional screen? So because of that, you can follow specifically with the patient, not the diagnosis. And I know like we're always taught in school, each patient is different, even though they may have the same diagnosis. But then when you go to the clinic and you're thinking along of how do you treat the diagnosis, so that part doesn't really mix well. So it's nice that we don't follow really diagnoses very much at all, and then looking at functional screen and what they do on the table is a lot easier to guide the treatment.
Okay. So you brought something else up there. Talk about what it's like to go from, so this morning, one of our first patients, actually the patient that we just got done with was an older individual, low back pain, hip pain, knee problems. She's in her late 60s, maybe early 70s. And before her, we had a high school cheer athlete who was obviously much younger, obviously much more athletic, obviously doing different things. She's coming in for a labral tear, so the patient that we've done the case study on. Talk about what it's like to go from a patient that are polar opposites, but you're still using the same thought processes, so you don't have to change your thinking depending on what the patient is.
Yeah, I think adapting to the patient is best. The screen, most specifically, like because of having hip and low back pain, mostly the low back pain with the older patients, you're looking at certain things on the screen of like stability wise, but then like with the labral tear patient, you're also looking at that, but then you're looking at more hip specific movements, which that's nice to kind of, because we know that there's limitations with those movements, you can assess them in the screen. So I think differentiating with that was helpful. In terms of like, what should we do HEP wise? Basing, again, what happened on the table, what they failing and passing NFT wise was easy to then say, which movements do we need to do because of what was passing and failing? And so looking at, specific to low back stuff and specific to labral tear, doing different stuff like that.
Okay. So if you're one of those, we're at one of those clinics where they're saying, well, you can't do certain things with that patient population, or you have to do this differently because that's a different population. No, they both have the same physiology. Don't worry about treating the diagnosis or what they're doing. Worry about what can they do on the physiological aspect, and that's going to drive the rest of your thinking, which will get you to their exercises. And then that is what is guiding your thought process versus, oh, this person is this old and they have this condition, so I can't do these things over here. You should be doing those things just like you're doing with everybody else. What do you think? So leaving now after 6 weeks, and typically, like I told Josh this, typically if I had somebody come in for a 6-week rotation and they haven't been through the shift, they're probably not going to get their hands on people. They're probably not going to learn NFTs, palpations, all that kind of stuff, because you haven't had all of the background information that we teach in the shift. Well, Josh did a fantastic job of learning everything that I've put out there, and then using some aspects of critical thinking to connect some of the dots. So when he came in, he was asking really good questions. He picked up on stuff really quickly. So I ended up teaching him some of the NFTs and palpations. So now that you've learned that stuff, what would you say, and you've been doing NFTs for 3 weeks and palpations for 2 weeks. So even though you've had that much time to work on that stuff, how much does it feel like you still have to work on?
Yeah, a ton. And I'll do the tests that I know, and then even now, like I'm seeing like kind of new things of like where Rhett's palpating or where his hands are when he's testing. So there's a ton of stuff that I still don't quite understand of specifically like where to put your hands and where to apply force and stuff like that with NFTs and palpations. So yeah, there's still a lot to be learned for sure. Yeah.
And it took him a while, which it takes everybody a while. Like just because you have the person in the right position for the NFT. So if you're watching my videos and you're like, well, I have them in the exact same position that Rhett does. If you're not pushing them in the right plane, it doesn't work.
Yeah. Yeah. There's a couple times where I was like, oh yeah, the passion's good. And then Rhett would come into it and then either he'd be like, no, or you could literally see their knee bending when it shouldn't be because of just his force wasn't in the same plane that mine was.
Okay. Anything else like take home, like your biggest take home moment from this rotation?
With post-op patients, it was really interesting to see. I think you've got to have a really good understanding of like timetables with tissue healing. I think that really helps guide stuff of if you get to a spot of a post-op patient and you're kind of unfamiliar with that surgery or something like that and kind of forget that like certain movements are not okay at like say 3 weeks or 2 weeks, then I think that can really halt treatment in any clinic. And so I think that's really helpful to know that, which I've seen Rhett do that, has been helpful to see like, oh, if I can have a good understanding of tissue healing times, then it can guide treatment a lot.
Okay. And then, so we just did his final evaluation, and some of the things that we checked on there was like we didn't get to. So like the part about exercise. So Josh is good at educating patients on the exercises that we give people, and he's good at coaching them through how to do the exercises correctly. But what he said on the final was, I'm not really sure myself as far as progression from the basic exercises. Like I see you progressing them and doing different things, but I don't know like why. And if you walked away, I wouldn't know what to progress them to, or if they're having difficulty, how to regress them. So that's more stuff that we still have to learn. So when you go through the shift, that's all the stuff that we're jamming into 4 months. So after 4 months, you should know all of the NFTs, all of the palpations, how to progress and regress exercises. So the stuff that Josh learned here for 6 weeks is going to make him the best PT in the clinic that he goes to on the next rotation. So he's going to be doing stuff better than a CI, but he only knows this much of 180 system because he didn't go through the whole shift. So when I tell you guys, you can't learn this stuff you can't teach yourself how to do this by watching me do what I'm doing. So that's what Josh did, and he did a fantastic job of figuring things out and taking it to the next step. But he's still not to the point where he can say, I feel like I'm crushing 180 and doing this.
For sure. Still more to know for sure, yeah.
Yep. Okay. So just wanted to give you a behind the scenes. So does 180... so think back to the first time you saw whatever clip it was that you saw on Instagram with me talking about whatever. Okay. And you're kind of like, I don't know about this. So from there till now, does 180 work?
Yes. Yeah. And that I remember thinking of like, obviously you're not here and you can't really understand what's going on. So you're a little biased and you're thinking, like, what's going on there? And so, but being here in literally the first week and second week too, seeing like dramatic differences in certain patients of pass fail and like them feeling like they're stronger and then moving better on the screen after, that was really important to see for me to know that, hey, like this stuff works.
Okay. And is it not only easier than it looks, but also harder and more intricate than it looks?
Yeah. At the same time, that's a good point. It seems more structured, and in that way it makes it easier. And at the same time, there's a lot more details that you can't see through a video that makes it more difficult. Yeah.
So when we got done with the whiteboard little exercise that we did in the previous post, Josh stood back and he looked at the whiteboard and he was like, if I tried to explain this to somebody in school, they would have absolutely no clue what is going on here.
Yeah. The line, I don't know if you've seen the video, the lines on that video, it's like it looks so confusing, but having done that eval in person and then being able to write on a board what that would look like, it's a lot easier to understand that. But yeah, looking at having not done an eval and looking at that board, it may look confusing. Yeah.
Okay. All right, so that's Josh's rotation. We won't have another student for a while, so we won't do any student videos, but I hope you got some good insight from him, listening firsthand to somebody who's here and seeing what's going on, putting his hand on people, and his takeaways and still things that he needs to work on as he moves forward in the rest of his year and a half of PT school and then getting out in the clinic.